Welcome, everyone. Thank you for joining today's webinar. My name is Francesca Allman. I'm the Director of Sales at Benefits Canada, and I'm your moderator for today. Before we begin, I would like to acknowledge that this gathering, while virtual, is attended by delegates across Canada in lands traditionally used and occupied by numerous Indigenous nations. With this in mind, we do wish to acknowledge the land and recognize the long history of First Nations. Show them our respect today. We encourage you to reflect on the land you reside on and learn about the relationship Indigenous people have with the land historically and presently. Today's webinar is part of our Drug Innovations series. It's designed to bring new drug and disease information to you, our plan sponsor and advisor audiences, directly from pharmaceutical companies and their chosen speakers. Our speaker today is going to cover the links between type 2 diabetes and obesity and show how they can impact employee health and productivity. You will be given an overview of some new type 2 diabetes treatments and why employers should consider them for their drug plan management. I would like to thank today's webinar sponsor, Eli Lilly, who has committed to this topic with passion and purpose. So now, just a few housekeeping notes before we get started. This here is an example of an attendee interface. You will see something similar on your own computer desktop in the upper right-hand corner. Use the orange arrow to open and close your control panel, and the audio tab to select your preferred audio, whether it's mic and speakers to use your computer or telephone to dial in using the information provided. There will be an opportunity for you to ask the speaker questions today, so do feel free to submit them as we go along. Just type them into the questions pane of the control panel. We will collect and address questions during the Q&A session at the end of this webinar, so you can go ahead and start typing them at any time. We will collect them. So now it's my pleasure to introduce to you our speaker today, Dr. Sue Pedersen, specialist in endocrinology and metabolism. Welcome, Dr. Pedersen, to the virtual stage. Hi there.
Thanks so much, Francesca, and thank you so much, everyone, for joining us today. We were just having a little pre-meeting chat, and I wanted to share with all of you also, it is really an honor to be here with you this hour to talk about the importance of having access to wonderful new and emerging treatments for type 2 diabetes for our patients. So thank you very much.
Thank you, Dr. Pedersen. Have a great presentation. I'll see you at the end for some Q&A.
Sounds great. Wonderful. Okay, well, let's get started. So I'm just going to take over the screen here. Wonderful. So my name, as you have heard, is Sue Pedersen. I'm an endocrinologist in Calgary. I'm a diplomat of the American Board of Obesity Medicine as well. So my focus and my passion is really in the management of people with type 2 diabetes and people with obesity. I'm in charge of our clinical trial program, so I'm involved in a global level in development of many of the medications you're going to hear about today. And I'm also the lead author of the pharmacotherapy chapter, which is the medications chapter of the Canadian Obesity Guidelines. And I'm also an author on the weight management chapter in the Diabetes Canada Guidelines. So I'd like to take you through a discussion about the revolution in diabetes care and why patients need access to these important, powerful new treatments that can really improve patients' overall holistic health. So we'll have go through about 40-45 minutes of the presentation, and then I really welcome your questions. So please do type them in the chat as we go. I think we've got over 300 people joining us today, so maybe we'll see 300 questions, and we'll take as many of them as we can towards the end. Great. So these are my disclosures related to my research involvement, and I do a lot of education domestically and internationally as well. So the topics that I put together for us to talk about, first of all, are to talk about the health and work consequences of people with type 2 diabetes, how their diabetes impacts their life in terms of health issues and also their capacity to work. We'll then talk about the health and work consequences of obesity. And then we'll talk about the overlap between type 2 diabetes and obesity, which you'll see is there's quite a lot of overlap there. And again, one of the themes I'd like you to come home with today is the importance of these medications that we have to treat both diabetes and obesity together, because that's so important. We'll go through what the current guidelines recommend regarding weight management in people with type 2 diabetes. And then this is not a typo. This is both an evolution in treatment and truly a revolution. Patients are now asking for these medications. They come in and ask for them by name, even those that aren't available in Canada yet. So patients are driving this, and they are asking their insurance companies, the places they work, we need you to pay for this medication to improve my health. So this is not only an evolution in terms of the efficacy of these treatments, but also really a revolution, that these are now things that patients know about, and they're asking for them. They're asking their employers, they're asking their insurance companies for coverage for these important treatments. So I've got some polling questions for you today. So this is the first one. We'll just be quick, like maybe 15, 20 seconds. So in your role as an insurance provider or involved in patient care or pharmaceuticals, these are the groups that are with us today, please select one of these. So is it far more important to treat diabetes than obesity? Is it slightly more important to treat type 2 diabetes than obesity? Are they equally important? Or then you can read the fourth and fifth on your own. So I'll just let you enter something there. And then Tracy, I don't know if you can see, but once we've got sort of a quorum, then we could just show the results, please. Okay, so most of you said that treating type 2 diabetes and obesity are equally important. Hooray, I fully agree with you on that. That's excellent. So we'll return to the slides now, Tracy. Great. Okay, so let's just talk a little bit about the prevalence of these conditions in Canada. So the prevalence, or the proportion of people who have diabetes in Canada, is gradually going up over time, as we see. I think this little blip here was probably less diagnoses during COVID because of lack of access to healthcare and lab testing and so forth. But in general, around most countries in the world, we are seeing a progressive increase in the percentage of people who have type 2 diabetes. So currently, over 2 million Canadian adults have type 2 diabetes. So this is a very common condition. And even a much larger number of people have pre-diabetes. They're on the verge of developing type 2 diabetes. So if we can treat them even before they develop type 2 diabetes, then we can prevent diabetes from happening in the first place. We'll come back to that as well. Worldwide, we have challenges in getting to a good blood sugar control in diabetes. So good blood sugar control is important, and we'll come to a little more data on that. But really, if you have poor blood sugar control, you have a higher risk of developing complications of diabetes over time. So the general target is a blood test called the A1C, which reflects blood sugar over the last 3 months, and the goal is to have it at about 7%. So only about half of Canadians actually are at that target, and there's many things limiting that target. Some patients who don't have access to these newer medications have choices that are some of the older, cheaper medications like sulfonylureas. People may have to go to insulin, whereas these newer medications may prevent them from having to go to insulin. That's associated with weight gain, which worsens the obesity, can cause low blood sugars, which can be devastating, also cause fear, can make it harder to be productive at work because of low blood sugar. So there's a lot of things that limit this control. So globally, similar, only about half of people are actually at their A1C target. Now, we know that the higher the A1C, the higher the risk of developing diabetes complications over time. Conversely, it makes sense then that if we can reduce the A1C, bring it closer to target, we have a lower risk of complications. So here you can see, even if we can get that A1C down by 1%, we can reduce complications markedly. And just to give a general number here, when I'm counseling patients, I say, if we can reduce your A1C by 1%, we reduce your risk of overall complications by about 20%. So that's kind of an average of all of the different complications you see here. And with a 1% reduction in A1C from a cost perspective, because now people are healthier, less complications, there was a 13% reduction in diabetes-related costs. So it is a cost savings to help people to get to their target A1C and improve upon their A1C. The burden of type 2 diabetes in Canadian workplaces is very significant. It's more difficult to be productive at work. We're more likely to be absent from work. And of course, there's increased disability. When we think of the complications that you saw on the last slide, heart attacks, strokes, eye complications, neuropathy, which can cause foot sores, amputation, kidney failure, dialysis. So you can see that, of course, a patient who is carrying a heavy burden of these complications is going to have more difficulty being productive or even present at work. So the reduced productivity and missed work cost employers about $1,500 a year in Canadian data. And it's not just the diabetes direct complications, but it's also other conditions that are seen with diabetes, like depression, mental health issues, even ability to drive to work. There's such a long list. People with diabetes are absent 2 to 10 days more per year from work than those without diabetes. And the more complications you have, so if you're a patient who has kidney problems, eye problems, heart problem, depression, hypertension, they may miss 3 weeks of work compared to someone who doesn't have type 2 diabetes. So we can see that helping to keep our patients healthy, people with diabetes, helping to prevent complications or prevent them from progressing, having good control, is really important from a financial perspective for you to think about that as payers, hopefully paying for the important medications that we need. Now, if we turn to obesity, the percentage of people in Canada with overweight or obesity is also increasing, and we see this around the world as well. So if we look at people with overweight, so this is based on what we call BMI, or body mass index criteria, which is a number calculated based on weight and height. So people who have overweight, that's a BMI just mildly elevated, so between 25 and 30, and people with obesity is with a BMI of 30 or greater. So when we put these numbers together, we see that the majority of Canadian adults carry elevated weight. So it's actually a minority of the population who has a healthy body weight. So the majority of people have this problem and need the help with tools, including medications, to help manage their obesity. Okay, so in thinking about why it's so important to treat obesity, which of the following health conditions do you think are not related to obesity? So if you think it's nothing to do with obesity, then check it off, and then we'll see what you think. And you can choose more than one if you think there's more than one that's not related to obesity. Okay, Tracy, let's see. Okay, so the only of these medical conditions, and Tracy, I hope everyone else can see the results here. So there was a smattering of votes for most of these conditions. So the only one of these conditions not related to obesity, with a caveat, is actually osteoporosis. So Alzheimer's, cardiovascular death, meaning death from a heart attack, asthma, and psoriasis all are more of a problem or get worse with higher weight. Osteoporosis, you need higher bone density tends to go up when you have higher weight. So you tend to have stronger bones to support that weight. But interestingly, that one even has caveats, because there is some data that people with more severe obesity may actually be at higher risk of fracture. So we won't get into the complexities of that. But I bring this up to you to point out there are actually over 200 medical conditions associated with obesity. And this is just a smattering of some of the main ones, but there's actually over 200. So you can look at any body system and see that there are health issues that can be related to carrying elevated body weight. So treating our patient holistically, treating their type 2 diabetes, treating their obesity, helping them to lose weight with medications that treat both, can also improve a whole host of other health conditions, which you can look at, pick one, that these conditions also could affect the patient's ability to be productive at work, or require absence from work, or require a CPAP machine for sleep apnea that costs money, or require 5 medications for blood pressure that cost money. If we can improve their health, improve their weight, we can maybe have them not need many of these other treatments, as well as helping them to be more involved and productive in the workplace. Okay, next polling question. What percentage of people with type 2 diabetes do you think also carry elevated weight? So now we're talking about what's the overlap here. So I'll just let you vote here, give you about 10 seconds. Okay, Tracy. Okay, so there's a smattering of responses here. The correct answer, if we just go back to the slides, is 90% of people with type 2 diabetes also carry elevated weight. So it is the minority of people with type 2 diabetes who do not have overweight or obesity, about 10%. But actually, if you were to look inside and look at their internal body composition and fat composition, we actually see that those who look like they have healthy weight based on the BMI actually do have elevated amount of fat tissue if you were able to look inside, like with a CT scan or a DEXA scan, or some kind of way to look at body fat composition. So again, you know, when we think about these new treatments and think, well, okay, so if we want to approve these new medications for type 2 diabetes, well, how many actually are also going to benefit from a weight management perspective? 90% of people have elevated weight. So as most people with type 2 diabetes also need help with weight management. It is the infrequent patient in my practice where we would not want them to lose weight. That happens sometimes. There are people like that, but the vast majority also can benefit from weight loss. So if we look now at people who have type 2 diabetes, if we look at if their weight is higher, so if we look at classes of body mass index here across the x-axis here on the bottom, we see that the higher weight that a patient carries, the higher likelihood that their A1C or their diabetes report card, their blood sugars, are not controlled. So the message here is people with higher weight have a harder time to control their blood sugar. So again, speaking to that need to have medication that can powerfully reduce blood sugar and help them manage their weight. If we look at people with type 2 diabetes, also the ranges of overweight and obesity are associated with a higher risk of complications of diabetes. So if we look at NHANES data, people with obesity, BMI greater than 30, with type 2 diabetes were 23% more likely to have complications in their kidneys, in their eyes, in the nerves in their feet, maybe having foot sores, amputations, that sort of thing. And they were 56% more likely to have a history of heart attacks, heart failure, or stroke. Now, if we look at as weight goes higher, so here this bottom study looked at BMI 5 progressive categories. So we can kind of think of that for the average person, that would be about 30 to 35 pounds higher weight. So for every 30 or 35 pounds more, you have a 20% higher risk of having complications in the small vessels, eyes, kidneys, feet. You have a 38% risk specifically of having chronic kidney disease with each 35-pound higher weight, and a 12% higher risk of having nerve damage. So again, speaking to that need to manage weight and diabetes together. Now, from an economic impact of obesity, if we look at Canadian data, if we look at medical conditions associated with obesity, and this is, of course, we talked about there's over 200. This is just some of the big hitters. Type 2 diabetes, hypertension, which is high blood pressure, heart disease, stroke, and then back pain is an important one for absenteeism and not being able to be functional at work as well. And we look at direct costs and indirect costs, we see that many of these top $1 billion. And when you look at the direct costs related to obesity, it's estimated about $6 billion, which is about 4% of Canada's total healthcare budget. In the United States, there was actually an article in Reuters that I read this morning. I think it was published within the last day or two. And in America, they had this estimated at about $100 billion for the direct costs of obesity. So again, ignoring obesity is not acceptable. Telling patients to eat less and move more is not acceptable. We'll talk about why. We need medications that help people with elevated weight. Okay, now looking specifically at obesity and work productivity in Canada. And again, here we've got BMI, weight by BMI category. So this is the what we call the healthy weight category here, underweight, and then progressively higher body weight. We see in red absenteeism, and then in gray, which is presenteeism, meaning I'm present at work, but I'm not able to function fully. And we can see that with a higher weight, you have a higher likelihood of being absent from work and also a higher risk of being present but not functioning fully, which is of course very costly to companies that are employing these patients, and of course very unpleasant and unfortunate for the patients themselves. Now, you might be wondering, okay, well, so I understand that there's a lot of health issues associated with weight, but do patients have to lose like 50 pounds, 100 pounds in order to have a benefit? The answer is no. In fact, even with a small amount of weight loss, blood sugar in particular is very sensitive to even small changes in weight. So much so that if a person with pre-diabetes has a 1% weight loss, they reduce their risk of developing diabetes by about 16%. So very powerful, small amount of weight loss can give a powerful reduction in even developing diabetes. And when you have diabetes, reducing weight even a little can really powerfully improve blood sugar control. Now, to get improvements in things like cholesterol, blood pressure, fatty liver, polycystic ovary syndrome, we need to see about 5 to 10% weight loss. To get improvements in sleep apnea, bigger improvements in fatty liver, knee osteoarthritis pain, which can limit productivity at work, of course, as well. Heart disease, we're seeing we need 10 to 15% weight loss. If we want to put diabetes into remission, meaning bringing sugars to normal without any treatment, reduce cardiac death or heart failure, then we need to see probably 15% or more of weight loss. Okay, I think this is the last polling question. Why do you think it is so hard for most people to lose weight and keep it off with lifestyle change? So we know the vast majority of people are not able to lose weight and keep it off. Why do you think that is? So please select what you think is most likely. Okay, let's see. Okay, so we've got lots of variety of responses here, kind of equal for lacking willpower and the fullness hormones, and then some for not enough physical activity. So let's talk about the biology of weight. This is really important to understand. So when we lose weight, our bodies are evolutionarily built to think there's a famine, and all systems get engaged to try to get us to regain the weight, because evolutionarily our body wants us to survive the famine. So when we lose weight, we have a hunger hormone called ghrelin. It goes up because it wants us to be hungry, right? It wants us to be hangry and hungry and eat more, go find food and find it now because you need to survive the famine. So the hunger hormone goes up. The correct answer from that question we just had is that the fullness hormones go down because our bodies don't want us to feel full. Our bodies want us to feel hungry. So GLP, which is a hormone that our guts make, that these new medications we're going to talk about are based upon, that's a fullness hormone. It goes down when we lose weight. We're developing medications that include amylin. PYY is being explored. So we're actually capitalizing on this physiology, this natural biology, to develop medications that can put a defense in place against this. Also, when we lose weight, our energy burn goes down. All the little furnaces in our 6 billion cells called the mitochondria, they slow down because our bodies want us to conserve energy so that we will regain the weight. And these changes persist long term. There's no endpoint to these changes. So this, friends, is why it is so hard for people to lose weight and keep it off on their own. It is not a lack of willpower. It is not because they don't want to. It is because their biology is powerfully defending them and pushing them to regain the weight. So that's an important message for today. And this is why we need medications that can put the brakes, put a defense on this, and use some of these hormone-based strategies to put the defense in, give more fullness to our patients so that they can more easily resist that and help to manage their weight more effectively. Oops. Okay, so another key point for you guys today is that we want to treat diabetes and obesity. We want to treat earlier, and we need to treat long-term. So where we often are treating patients with type 2 diabetes is over here on the right, where they've got complications, they've got heart failure, they've got hypertension, they've got some kidney problems, they're on a CPAP, expensive sleep app machine for their sleep apnea. We need to help them manage their weight here and improve their diabetes control to prevent their health issues from progressing. This is true. But now imagine we had treated our patient more aggressively earlier on, and we could use medication that treats type 2 diabetes and weight together before they get complications, before they have heart failure and all of the expenses of being away from work and hospital admissions and so forth, before they have sleep apnea and need a CPAP machine. Then we can prevent, and that's also very cost savings. It gives our patient better quality of life, better ability to be productive at work, and can prevent these health complications from developing. Now imagine we treated them even earlier when they have pre-diabetes. If we can prevent diabetes from happening in the first place, imagine the improvement to that patient's life, their quality of life, and the cost savings as insurance providers not to have to pay for these expensive complications developing. And if we even go earlier and now talk about treating obesity before they develop pre-diabetes, diabetes, and so forth, and use obesity medication, now here we can have a very powerful impact to disrupt this whole natural progression and hopefully prevent them from developing pre-diabetes, metabolic syndrome, and all these health conditions in the first place. So I implore you to be receptive and hopefully engaged in approving treatments that can help to treat our patients earlier in this natural progression. It benefits the patients and it benefits you from a cost perspective to prevent all these complications from happening. Okay, so what do our guidelines in our country and other countries as well recommend regarding weight management in people with type 2 diabetes? So in our Diabetes Canada guidelines, as we talked about, we generally are looking to achieve an A1C, which is that diabetes report card of about 7%. In weight management, Diabetes Canada suggests a 5 to 10% weight loss. Now, we try not to put the focus on numbers on the scale. We try to put it more on improving health, because that's what it's all about. And different people will need different amounts of weight loss in order to realize health improvements. But as a general kind of realm, Diabetes Canada says 5 to 10%. In our Obesity Canada guidelines, we're a little more aggressive than that, because we're looking maybe a little more focus on some of the complications of obesity other than diabetes. Like we talked about, 15% can really improve heart failure, for example, or perhaps reduce the risk of cardiovascular events like heart attacks and so forth. So for most people, depending on how much obesity they have, for most people, if we can get them to the 15% range, that's very beneficial, but different for different people. Some don't need to lose that much and some benefit from losing more. Now, this is our algorithm for our Diabetes Canada medication choices, and it looks very complicated, and we're just gonna look at this at a very high level. So don't worry about. I'm not going to bore you with a whole bunch of details, but what we do in Diabetes Canada and what's recommended for diabetes patients in Canada is that A1C, that report card, needs improvement. So we need to lower blood sugar. We also need to think about, does our patient have heart or kidney problems? Because there are two classes of medications that have been shown to protect the heart and protect the kidneys. And those are GLP-1 receptor agonists, which we'll talk about more today, and the SGLT2 inhibitors. Now, if our patient doesn't have heart or kidney complications, it still prioritizes the GLP-1 receptor agonists and the SGLT2 inhibitors because they do protect the heart, they protect the kidneys. Both of these classes cause weight loss, which most people with diabetes can benefit from. The GLP-1s particularly powerful for weight loss. And neither cause low blood sugar. So we don't want patients to ever have low blood sugar, ideally never, and neither of these groups of medications cause low blood sugar. Now, if we look at the effect of the diabetes medications on weight, we see that we have the GLP-1 receptor agonists and the SGLT2 inhibitors here that cause weight loss. Currently available in Canada, semaglutide, which you may know as Ozempic, gives the most weight loss. And then we have the meds that cause weight gain. So this is not benefiting our patient with type 2 diabetes and obesity. So here we have the sulfonylureas, the insulin, and then actose or pioglitazone. We don't use that much anymore, but we ideally would like to avoid these medications if possible in people with obesity because they will promote weight gain. Now, that being said, many of my patients are on insulin, but they are also optimized on a whole combination of these medications that help to mitigate the weight gain. In America and Europe, these are, I would say, globally the leading guidelines for type 2 diabetes. They have now put a three-pronged approach on the priorities of diabetes management, and that is the heart and kidney protection, like we've talked about, blood sugar control, as we've talked about, and weight loss. So they are the first guidelines in the world who have put weight loss as right up there with let's protect against heart attacks, strokes, heart failure, and glucose control and weight all together. So we're really seeing a movement globally towards recognizing the importance that we have to treat type 2 diabetes and obesity together. Okay, so what do we have in our armamentarium of treatments that can treat diabetes and obesity together? And here we're going to focus on the GLP-1 receptor agonists because, as we've talked about, these are the medications that give the most weight loss and most powerful glucose lowering for some of these medications as well. So we have daily injectable GLP-1s. We don't use them much anymore because the weekly injectables have really taken over. So Bydureon doesn't work very well. It's very little used. So semaglutide or Ozempic is far and away the most commonly used GLP-1 because for what is available currently, it's the most effective for blood sugar lowering and weight loss. And it's also covered very, very widely by by provincial programs and, of course, private insurance. Dulaglutide or Trulicity is also used. It's a once weekly injectable. We have a pill form of GLP-1. So this is Ozempic in a pill, and it's called Rybelsus. So that's a once daily pill that you take. And then we have this very, very exciting new weekly GLP-1, which is combined with another hormone, another one of the fullness hormones called GIP. So this is one medication that targets both GLP and GIP called tirzepatide or Mounjaro. So this has been approved in Canada since November last year and is expected soon on shelves. And patients are asking about it frequently. It's all over, social media, and patients know about this. They're asking about every day. I get asked, is Mounjaro here yet? Because they've heard about the efficacy both for diabetes control and weight loss. So let's talk about that. So first, I'll just take you through the Ozempic data. So this is semaglutide injectable or Ozempic across a very large clinical trial program. The A1C reduction was for the higher dose of Ozempic of 1 milligram weekly was 1.5 up to 1.8%. Remember, 1% A1C reduction reduces complications by 20%. So here we're getting 1.5 to 1.8% reduction in A1C. So very powerful. From a weight loss perspective, with Ozempic 1 milligram, we see 5 to 6.5 kilos of weight loss, so up to about 15 pounds. So that's very important. That's an important weight reduction for these people with type 2 diabetes, the vast majority of whom also have obesity. Ozempic is also available and approved at 2 milligrams weekly. So this is based on this data, which shows that if you use Ozempic 2 milligrams, you get a little more A1C reduction than using Ozempic 1 milligram, so 1.9%, 2.2% with the 2 milligram dose. And you also get a little more weight loss with the 2 milligrams as opposed to the 1 milligram dose. So 2 milligrams is approved and covered by some insurance programs. Now for the oral version of semaglutide, which is like oral Ozempic in a pill, which is called Rybelsus. Again, here we see about a 1.5% A1C reduction, actually up to 2% in one of the studies. So again, very powerful to reduce blood sugar. And here a 4 to 5 kilo weight loss, depends on the study. It varied depending on the study. But again, an important amount of weight loss and blood sugar control for Rybelsus. Now, Trulicity is available in Canada at the 1.5 milligram dose. That's the one of the other weekly injectables that we use. It is actually approved up to 4.5 milligrams, so triple that dose, but it wasn't marketed for that in Canada. But it does show, again, more A1C reduction with a higher dose up to 1.8% and a weight loss up to 5 kilos with the higher dose. So we see that with more GLP-1 activity, higher GLP-1 strength, we get more A1C reduction and we get more weight loss. Now, tirzepatide or Mounjaro, as we talked about, this is what we call a dual agonist, so dually stimulating GLP-1 and GIP. So GLP-1 as a hormone, we talked about, it's one of the fullness hormones. When we eat, our guts release GLP-1, it goes to our brain, it tells us that we feel full. And GLP-1 can also have an effect to reduce cravings as well. And a lot of people struggle with cravings. It's part of that evolutionarily engineered system that wants us to eat more and have more fat so that we'll survive the next famine. So GLP-1 as a medication can help to reduce appetite. And some GLP-1 data has shown a reduction in cravings as well. Now, GIP is the other hormone receptor that Mounjaro stimulates. GIP is also one of the fullness hormones that our guts make. It also talks to the brain to tell us we feel full. And both GLP-1 and GIP, of course, from a diabetes perspective, importantly, talk to the pancreas and tell the pancreas to improve blood sugar by effects on insulin and other hormones involved in blood sugar control. So with Mounjaro, because we have two hormone actions working, both of which talk to the pancreas to improve blood sugar control, both of which talk to the brain to reduce appetite and perhaps an impact on food cravings as well, we may hypothesize that this may be even more powerful than the medications we currently have available. So let's look at the data. So the SURPASS program was a number of studies in people with type 2 diabetes looking at Mounjaro at the 3 approved doses of 5 milligrams, 10 milligrams, and 15 milligrams. This is also given as a small injection under the skin once a week. And here we see, friends, look at this A1C improvement. We see over 2% A1C reduction, as much as 2.6% A1C reduction. We have never seen A1C reduction so powerful until the SURPASS program came out for any other medication that preceded it. So a great proportion of people in a lot of these studies actually got to a normal A1C, got even out of the diabetes range of blood sugar control into more normal sugars. So this, again, remember, 1% A1C reduction reduces complication risk by how much? 20%. So if we now can get 2.5% A1C reduction, just think of the power here to reduce diabetes complications, give our patients a better life, a healthier life, and be a cost savings for other health complications to not arise down the road. And then finally, from the weight perspective, if we look at Mounjaro or tirzepatide's effect on body weight, again, we have the 3 approved doses, 5, 10, 15 milligrams. This is in people with type 2 diabetes, remember, it's the same studies as I just presented to you. Here we see up to 12.9 percent weight loss, which again, I mean, this is 26, 27 pounds. Again, this kind of weight loss in a group of people with type 2 diabetes with medication therapy is previously not seen in any preceding medications that we have available. I'll point out to you, maybe I'll just go back one slide here. The SURPASS-2 study was a direct head-to-head trial versus Ozempic at the 1 milligram dose. So we have the 3 Mounjaro doses here in blue, and then we have the Ozempic in the gray here under SURPASS. This, I don't think my mouse is working anymore, but hopefully I'm pointing underneath the SURPASS-2 column. So when you look at Ozempic versus Mounjaro, we see that Mounjaro was a lot more effective to reduce A1C compared to Ozempic 1 milligram. Now, Ozempic 2 milligrams, as we talked about, is also available for diabetes. It has not been tested directly versus Mounjaro, so we don't know what that comparison would look like, but certainly versus the 1 milligram of Ozempic, Mounjaro is superior. And then from a weight perspective, again, just to zone in on the SURPASS-2, which is versus Ozempic, we see double the weight loss with Mounjaro at 15 milligrams compared to what we saw with Ozempic at 1 milligram. So if you're wondering, well, you know, Ozempic is used so broadly, you know, maybe you're in a company or a program that covers it, why should we be thinking about paying for Mounjaro? It's now going to be available very soon on Canadian shelves. Well, this is the reason. We see more A1C improvement. We see greater weight loss compared to Ozempic 1 milligram. So potentially could have an even more powerful benefit to our patients. So, and again, you know, your companies who have insurance companies, people are asking for this. Like I said, every day I hear about when is Mounjaro coming? So this is going to be, and healthcare providers, physicians, I'm sure you can hear myself, I'm very excited to have my hands on Mounjaro in my clinical practice to be able to offer this to my patients. So you will see a powerful drive and requests from both healthcare providers and from patients asking for Mounjaro. So to bring it all home, and I really do welcome your questions. So if you haven't started typing in the chat box, please do. I want to hear what you have to say. Type 2 diabetes and obesity, both individually and together, I hope that you have been convinced, if not already, that both these conditions have a profound negative impact on people's health. Both are associated with a large direct economic cost, and both have a negative impact on workplace productivity. Managing type 2 diabetes and obesity holistically and together are essential to improve our patients' health, to reduce complications, to improve their quality of life, to help them to be able to be at work and productive at work. And our guidelines that direct doctors in Canada, like me, to treat patients are recommending that we follow this approach of treating both together. And remember, treating earlier, we can disrupt the natural progression of many of these health issues and hopefully prevent them from even getting sick with these expensive conditions in the first place. And you know, we're now in a very exciting time where we have treatments that are now approved, available, very soon to be available on shelves with previously unseen capacity to improve the control of type 2 diabetes and help our patients manage weight. And again, you know, from my heart as a healthcare provider, I've been in this world and had this passion for diabetes and obesity for 20 years. I feel so blessed and honored to be here to ask you to please consider making these medications available to the people, to the clients that you have in your purview. Every one of you, I hope that I have convinced you of the importance of access to these treatments. I get a little emotional, sorry. And then finally, if you haven't seen it, this is my blog, my website. So I've got over 2.7 million hits. I publish something once a week. I've done that for many years. And a lot of these questions I blog about. I have a lot of readers around the world, lots of readers in Canada. If you want to think about these things more, or if you're wondering what I think about, well, what happens if you lose weight and gain it again? Is that bad for health? Or just some quick summaries from or notes from today. I invite you, these are just some screenshots from some of the blogs that I've published on these topics. You can subscribe in the top. Please enjoy. And now I think I'll turn it to Francesca to open for questions.
Thank you so much, Dr. Pedersen. I can see your passion and knowledge, and you're an influencer, that's for sure. That's a lot of followers. So that was incredibly relevant, and I've got a lot of questions coming in, as you can imagine. So I wanted to just remind everybody, Q&A, if you haven't yet submitted a question, you can do so on the questions pane. So you can type those in, and I'm trying to filter through and get to the big ones and burning ones. But one of the things that really just wanted to dial right back to near the beginning of just sort of the basis of all of this, and maybe some myths around obesity and diabetes. And can you maybe just comment quickly as we set the stage for some Q&A about how, some people say, oh, if you're obese, you've brought this upon yourself. So can you just sort of take us back to like commenting on the myth or the stigma of diabetes and obesity?
I sure can, and thanks for bringing that up. So there remains a very pervasive and powerful weight bias and stigma out there, and it's actually worse amongst healthcare providers than it is in the general public. So I think we're all general public members. I think we know how bad it is in general public. If you look inside healthcare, it's even more so, which is very distressing to me and to us at Obesity Canada as well. This is why I brought those slides today and that discussion about understanding the science of obesity. Because if we think that, oh, well, this is just the person's fault, and so why would I pay for this medication when all they need to do is just think about it more and use their willpower? This is not a willpower issue. This is not the person's fault. This is the natural biology. A lot of it has to do with genetics as well. So genetics actually determines 40 to 70% of our weight, and also where we carry that weight. That doesn't mean we can't modify it within those genetics, but it explains why some people seem like they can eat whatever and they never gain weight, and other people feel like they look at something and their weight goes up. This is very much genetically driven, and there's many other factors that play into weight struggles as well, like other medications that they're on that could be causing weight gain. That's not their fault. A person with diabetes who's got has a foot ulcer and can't be active, that's not their fault. So we really, and then that science of weight, that biology, to understand that what happens when you lose weight or you try to lose weight, those hormones kick in, evolutionarily driven, to powerfully screaming at your brain to regain the weight. And then our metabolism goes down when we lose weight as well. So all of these, understanding the science is really important as a piece to overcome that bias and understand that obesity is a chronic medical condition that needs long-term treatment.
And also, Dr. Pedersen, my audience, Benefits Canada, is very interested, of course, in mental health. And it's a big topic for the workplace and productivity. And is there links between mental health issues and obesity?
Very much so, yes. So actually in our Obesity Canada guidelines, if you Google Obesity Canada guidelines mental health, you'll right away see there's a whole chapter in our guidelines about mental health in obesity, because there is a complex interplay. Depression has a bidirectional relationship, meaning that obesity can cause depression, depression can cause obesity. There's many mental health medications that can cause often a lot of weight gain, and that consideration is often not given to there's actually another chapter in our guidelines about medications that cause weight gain and alternatives that can be considered, because we need to be thoughtful of that. Binge eating disorder, ADHD is very common, often not diagnosed, attention deficit and hyperactivity disorder, and can make it very difficult to adhere to a good blood sugar control treatment regimen, to checking sugars in people with diabetes, for weight management as well. And when they get their ADHD treated, wow, we sometimes see like their blood sugars improve a lot, their weight goes down, they find it better, easier to focus. So yes, there's a very important mental health aspect with obesity, yes.
So you really, as a physician and treating patients, you obviously, even just with talking about that element, you've got your hands full. And so when you're considering treating a patient who has these issues and those issues, I'm assuming that it's very important for you to have choice in how you're going to choose to treat X patient or Y patient or Z patient. So can you just speak to how important it is to understand the fact that, you know, currently semaglutide is, you know, it is covered mostly for type 2 diabetes, but then there's newer innovations that you've described, and it's so very exciting. And maybe some private payers will say, I don't want to bring something new onto my plan. It's going to, you know, impact my budget. So what would you tell private payers when they're looking at new things coming in, like Mounjaro that you've mentioned, from a physician's perspective, as you're needing to treat patients with all kinds of issues?
Sure. So we need to have options. So one medication does not work for everybody. There's some people who don't tolerate it, for example, and perhaps with a different treatment, they might have better tolerance. There's some people in whom with semaglutide, we still could have, it would be beneficial to have something that's even more powerful to give more blood sugar control, more weight reduction. And again, it just, you know, versus Ozempic 1 milligram, we know that Mounjaro is superior. The higher doses of Ozempic, we don't know for sure. Looking at the data, probably tirzepatide or Mounjaro is superior as well. So I would like to have the ability to choose different medications for different patients, because one medication does not fit all. I also want to have the option to switch a patient from something that they're already taking to try one of these newer medications to see if we can get additional health benefits.
Right, I can see your passion, and it is so important to get at the heart of the matter. And one of the things that you know, I actually dawned on me when you were talking about the knee osteoarthritis and some of the improvements in weight loss and all of the different things that can happen and can be improved, including something to do with the knee pain, productivity at the workplace. Should an employer be looking at obesity almost like a health and safety issue, especially for people that in their employ that are in a physical role? If physical improvement can happen as people are more productive at work, it's almost really a health and safety issue. Wouldn't you say that?
So do you mean for people who have like more like mechanical jobs, I guess, like where they're lifting
Sure.
or climbing ladders? And absolutely, yes. So people who have elevated weight, you know, everybody's different. Everybody's journey is different. Everybody, the way their weight impacts their health, the way it impacts, you know, their knees or their back pain is different for different people. But certainly by the weight on weight-bearing joints, we know that of course a higher weight, you know, imagine putting an extra 50-pound backpack on right now, you know, your knees would start to get sore, your back would start to get sore. So for people who are involved in occupations where you need physical capacity to move around and do things, absolutely, that helping them manage their weight can make it easier and even make that kind of job more accessible. I have job options for people who otherwise may not because they're limited by their weight.
Perfect.
And I'll just also point out that going forward, we are now doing studies with these medications specifically in these health conditions. So, you know, we've talked about type 2 diabetes today. There are also studies ongoing, about to be started or ongoing for many up and coming medications, looking at treating heart failure, looking at treating sleep apnea. These are weight loss diabetes medications, but because they are so powerful for weight loss, and they also have, GLP has anti-inflammatory properties as well. So we're looking at them in knee osteoarthritis. We're looking them as, you know, how much can we reduce blood pressure medications? And all of these things are designed to not only see what the benefits are to our patients, but also with the idea of payers then seeing this and saying, wow, yeah, this medication is really powerful to improve blood sugar control or to reduce heart failure, and so to kind of chip away at getting more approvals and coverage for these treatments.
Oh, there's a lot of benefits. I can see that for sure. And I guess some of the questions that are coming in, and there's a lot, and I apologize to the audience. I absolutely can't get to them all. There's a lot, but there is a few questions about taking these, I'll just say these types of medications like for life. Maybe you can dispel any myths or just educate around that element of length of time for taking these medications.
Yes. So I get asked this a lot. How long do I have? And patients and also doctors ask me, so how long do I need to prescribe these medications for? Right. And we need to think about, type 2 diabetes and obesity as chronic medical conditions. So they need long-term treatment. We don't cure diabetes with medications. We don't cure obesity with weight management medication. We control these conditions. If we stop the medication, the condition deteriorates or comes back. So there is not an end point to these medications, whether it's for diabetes treatment, whether it's for obesity treatment with or without diabetes, we need to continue long term.
Okay.
You can kind of think of it like, I'll just pose you an analogy. So if you have if a person is on blood pressure medication, how long do you continue that for? You don't stop it, right? Because if you stop it, the blood pressure goes back up. If a person has an anxiety issue and is on anti-anxiety medication, we're not curing the anxiety with the medication, we're controlling it. So we can think about all of these metabolic health conditions in the same way. We're not curing, we're controlling. If we stop it, the disease comes back or gets worse.
Okay, that's great insight. Thank you so much. And I guess really I just want to scale back a little bit and move on to really, the prevalence here and really why you're seeing such a growing prevalence of both diabetes and obesity.
Yeah. So, this is genetics have been there for millions of years, right? It's in recent decades where we have seen, if we look back from like 100 years or 60 years, let's say, where we've seen this real growth in diabetes and obesity. So the two parallel each other, right? So we know that 90% of people with type 2 diabetes also have obesity. So with more higher weight in our population, we will have more diabetes. There are many environmental contributors to this. So we live in a society that promotes a sedentary life. We have oversized portions and, cheap food. The cheapest food is also usually the least healthy food. So there's socioeconomic barriers to eating healthily. There's also a lot of environmental pollutants. You can type pollution in my blog. I blogged about is obesity in the air we breathe. I blogged on that, I think, last week. So I'll let you read that. Air pollutants, plastics, environmental chemicals that actually can make one generation changes in our genetics and promote obesity in our next generation, as well as how it impacts us in our own body as we're breathing it, eating it, drinking it today.
That's scary.
It sure is.
We only have a couple more minutes for questions, and I think that the most important thing I want to just try and leave people with is when you're dealing with your patients who have type 2 diabetes and you're working with them on treatment, how much are you working with them on the whole patient that they are, with diet and nutrition, even their mental health in type 2 diabetes, or even those patients who maybe you can help prevent type 2 diabetes? If you can just sort of close with diabetes management and some of or maybe even some tips for our employers about how they can approach their workforce regarding diabetes prevalence in the workplace and prevention.
So in diabetes, we have across Canada generally quite good access to diabetes educators who are often dietitians or they're nurses or pharmacists who help our patient with the nutritional aspects of diabetes management. So it's a team sport. We need multidisciplinary access to do this. There's also often in many provinces limited access to psychologists to help with the mental health aspects around diabetes. In Obesity Canada, we have what we call the 3 pillars approach to treatment of obesity. And so this overlaps with diabetes as well. And those pillars are not diet and exercise, because again, just saying to a patient, eat more healthily, be more active, that's not gonna treat their obesity, because that powerful evolution defense is gonna prevent that for the vast majority. So the 3 pillars are actually psychological support, medications, and bariatric surgery, which is like gastric bypass surgery, those surgeries that can help manage weight and also treat diabetes. And we use these pillars as appropriate to support our patients, with the outcome being a better ability to adhere to healthier lifestyles. So we still need, and I would implore again payers to support nutritional support, activity support, because patients need help with that. What do I do? Because we're so polarized by what we see as being like the normal dietary approach in society, which is actually generally fairly unhealthy from the food sources that we have. So having access to nutrition support is important, and really important, and a big barrier that we have is also the psychological support aspect. So again, for people with diabetes, there's a little bit of access sometimes to get to see a psychologist paid for. For people with obesity without diabetes, it's nearly impossible to get that for free. So if that can be covered by my patients who have insurance programs that pay for some psychological support, there are in most cities in Canada, there is access to psychologists who have special interest in this. And having access to those pillars of treatment is really important. It's not just all about medication, you're right. And I'm really glad that you gave me the opportunity to talk about those other points as well.
Well, thank you so much. And I'm actually going to mention mental health in a minute in my closing remarks. And actually, we have come to the end of our webinar, sadly. Dr. Pedersen, thank you so much for your time and your incredible knowledge that you've shared with this group today. So thank you again. And I'm going to just conclude by saying that when you exit today's webinar, you'll be prompted to answer a quick survey. So please do so. Let us know what you thought. Thank you again, Dr. Pedersen. I'm actually just going to now go on and mention that we have a couple conferences coming up that I'll be hosting, one of which is our Healthy Outcomes Conference. And obviously it's about wellness and health in the workplace. It's happening in person in Toronto. You cannot attend unless you're an employer. So this is a very special event only designed for plan sponsors, employers to attend, to really feel like they're together with their peers, digging into wellness and benefits and disability management, all in the workplace. And we're going to also award awards with our workplace benefits program to winners, and all of the finalists will be there. It's going to be a very exciting time. So if you're an employer, you can register. Also, then our next event on October 26th is the Future of Work Summit. So our editorial team is hard at work with an advisory board to churn out a new report, second year in a row, our Future of Work survey. We're going to be presenting it at this virtual event summit, along with some other really great sessions, including AI and HR. So it's a little bit of an HR spin conference, and I think that if you're an employer, you're really going to want to attend that. That's virtual. And another virtual event is our Mental Health Summit on November 7th. So, obviously Dr. Pedersen spoke to the importance of mental health awareness. And so we're going to bring this conference back in virtual format. I think we've been hosting it for around 20 years. I really need to do the math on that, but it's extremely important. And I've mentioned it a couple times during this webinar. And lastly, in person in Toronto is our face-to-face in drug plan management conference on December the 5th, and that's at the Arcadian Court. Obviously, the theme is very much around drug plan design, drug plan management, and everyone is welcome to register for that, unlike our Healthy Outcomes Conference, which is just for employers. So thank you all for your time. Have a wonderful afternoon and evening, and stay safe, everyone, and thanks again for joining. Bye-bye.